Good morning and welcome to day 2 of the 2021 AFTD Education Conference. I'm Ben Freeman, AFTD's Director of Development and Communications. I hope that you came away from day 1 of our conference feeling better informed, better equipped for this journey, and with greater perspective on it. It's amazing to see so many of you here from far and wide. We have so much more to share with you, but first I want to start with some housekeeping to make it easier for you to navigate the day's program. Throughout the day, whenever you have questions for presenters, you can share them in the Q&A tab on this site. If you'd like to communicate a thought or reaction with other attendees, or ask a question about navigating the conference, use the Ideas tab. If you're having technical difficulties or trouble finding your way to the live programming, you can also click Get Help at the bottom of your browser window. Finally, if at any point in the conference you hear a significant echo, it may be because you have 2 browser windows open. Closing one should address the problem, and if it doesn't, just reach out. Much of the day's program will happen in the view you're watching now, the general session room of the conference. At 1:15 p.m. Eastern, we'll all leave this room to join breakout sessions. You can access the specific session of your choice via the list on your agenda under concurrent sessions. After your breakout, be sure to return as quickly as you can to the general session room under today's date, and then click on the title Apathy and FTD. That'll bring you back to the general session room where you can watch the remainder of today's program. We're now going to launch our first polling question for the day. Answers you share will help to inform this afternoon's interactive closing session and bring hope to others. At this point, I'm going to be joined by AFTD volunteer Keri Allen. Keri's a talented social media consultant, and if you're familiar with the FTD Hotshot Challenge campaign that drew so much engagement in our community this fall, then you've seen both her skill with digital media and her dedication as a volunteer. Keri will give you a sense of what you can expect from today's program and what AFTD's resources can offer for families facing a diagnosis. Thank you for joining us, Keri.
Hi, thank you, Ben, and good morning, AFTD conference guests, and welcome. A huge thank you to Ben and the AFTD for this opportunity to be a small part in today's amazing event. I know that the vast majority of you here with us today have been touched by FTD in some way, and many of you may be new to this FTD journey. So if that is you, again, welcome. You have come to the right place, and we are so glad you are here. Though of course, I'm sure we all miss being together in person. I, for one, am incredibly thankful for the ease of access provided by this online format. If your situation is like mine, having this conference online may have made it possible for you to join today. This is actually my very first AFTD conference, as before this year, I was in the thick of our family's FTD diagnosis and caregiving journey with my father, to the point where it wouldn't have been possible for me to take a few days to join an in-person event. I had never even heard of FTD before someone I loved began showing symptoms. My father is now more advanced in his FTD journey, and I wish with all my heart that I had known years ago what I know now, which is that as devastating as FTD is, I'm not alone. There is help, there is hope to be found in this community, and there are resources that can make this journey easier. As we've adjusted to this journey, I've enjoyed lots of opportunities to bring my time and talents to volunteer with efforts to raise awareness and to help end this disease. That has included the privilege of interviewing with the fantastic gals at the Remember Me podcast, and working with an amazing team at the FTD Hotshot Challenge, a grassroots social media campaign primarily centered during World FTD Awareness Week. And together we've raised awareness and funds to support AFTD and to help find a cure for FTD. As I'm sure you all know, AFTD's resources and educational materials are true lifesavers for families and for caregivers like me, and I can't wait to dive into day 2. We're going to have a strong afternoon of programming planned today, including one of my favorite aspects of the conference, which are the breakout sessions. Those are listed in your conference agenda. Our main general sessions today include cultural perspectives on FTD, caregiving resources and support options, and of course, an AFTD update with highlights from our hands down most unusual year. I am particularly excited to join in on the 2 interactive discussion sessions today. And it's always a treat to get to connect with others on this journey, even if it is through online chat this year. Lots of powerful content coming your way today for day 2. So without further ado, Ben and I are thrilled to kick off day 2 of the AFTD 2021 Educational Conference. And we hope that today brings you help, brings you insight, and that it offers you new hope for your journey. Thank you.
Thank you so much for the great welcome, Keri, and for sharing your experience and your perspective with all of us. And now, Sharon Denny, AFTD's Senior Director of Programs, will introduce our first presenter. Hi, Sharon.
Hey, Ben, thanks. Hello, everyone, and welcome back to day 2 of our conference. Our first session today will be presented by Dr. Chiadi Onyike. Dr. Onyike is the Director of the Young Onset Dementias Program at Johns Hopkins University. He's also a member of AFTD's Medical Council. Earlier this year, a paper that he co-wrote, Frontotemporal Dementia, a Cross-Cultural Perspective, was published in the compendium Frontotemporal Dementias as part of the Advances in Experimental Medicine and Biology book series. Today, Dr. Onyike will share his perspective on what is known about FTD across cultures and the need for continued research and additional understanding in this area. Dr. Onyike, thank you for joining us today.
Thank you. Thank you, Sharon. It's a pleasure, as always, to collaborate with the FTD, to work with the AFTD. And I'm especially pleased to be speaking about this topic. It's a topic that's has been dear to me for a long time, dear to many as well. And it's, of course, very timely today, as we all know. I'm going to pull up my slides. And so I'd like to thank the AFTD for spotlighting this topic for this year's education conference. What I'm going to be talking to you about are the cultural perspectives in FTD, and the focus is, of course, on care and on research. I have, as Sharon mentioned, been very much involved in FTD work for many years as an investigator in research studies. Including clinical trials, some of which have been sponsored by the pharmaceutical industry, and I serve as a consultant, and I'm very much involved in a variety of activities that are pointing to treatment development. As we know, frontotemporal dementia is a complex condition. This is the reason why many people have a delay in diagnosis. So if you take, for example, Alzheimer's disease, generally speaking, the conversation can be framed around memory loss, and clinics are labeled memory clinics. And it's very easy. It's a very easy message, even though Alzheimer's disease is indeed is more complex than merely memory impairment. We don't have the convenience of a similar slogan in the frontotemporal dementia world. And the reason for that is that frontotemporal dementia comprises a variety of phenotypes, if you will, syndromes. The most prominent, if you look at the left-hand side of the slide, the classical view, the most prominent syndromes involve coarsening of conduct and behavior, or disintegration of language and communication. So you have patients who will present with a variety of behavioral disturbance, with a variety of combinations, if you will, of things like distractibility, indifference, impatience, carelessness, insensitivity, impulsiveness, and so on. Or they'll present with difficulty producing speech, or with difficulty understanding what is being said to them. So this is the classical picture. As research has progressed, we now have a fuller picture of the kinds of things that can happen with the conditions that we call frontotemporal dementia. So going beyond behavior and language, we now have syndromes that are characterized by Parkinsonian features, so stiffness of movement, tremors, and the like, or with progressive paralysis in the case of ALS. And even more recently, amnesic states that mimic memory states that mimic Alzheimer's disease have been described, and psychiatric presentations in those with the C9orf72 gene genetic mutation. Now, as if this were not problem enough, this clinical diversity, when at the level of the diagnosis, after a physician or a nurse practitioner or primary care physician or some other person has collected a clinical history, they might request, for example, a brain scan. And as you can see on the panel on your left, the kinds of areas of atrophy, which are meaning brain shrinkage, which are denoted by the colors that you see in those 6 panels, may vary depending on the constellation, depending on the syndrome. Now, looking beneath the clinical presentation, these syndromes, which are captured in this row of colors here, so there's the behavioral phenotype, that's one of the language phenotypes, there's another, and there's the ALS. Map at the brain level to shrinkage in different brain areas. They map to different kinds of inclusion bodies that are seen when you look at the brain under a microscope. And then in the case of families where this is inherited, they can map to different kinds of genetic mutations. So there's a great deal of clinical diversity, pathologic diversity, genetic diversity in frontotemporal dementia. This makes clinical diagnosis very complicated. It makes understanding, therefore, what is going on difficult. It makes for the diagnostic delay that many people experience. The reason I'm going into this now, it may feel off topic so far, but the reason I'm going into this now is to highlight the difficulty, that the complexity of this condition is a factor to be considered when we think about the cultural, the geographic distribution of FTD, or the cultural factors that might play into either getting a diagnosis, frankly, even the experience of having the condition, getting the diagnosis, having access to treatment, and the resources that can be brought to bear for that treatment. Now, there is fortunately a global distribution to the work that's being done to develop FTD care and to develop FTD research. So the map you see there with the flags shows where the major centers are. For those of you if there's anyone calling in from New Zealand, my apologies, there should be a flag in New Zealand as well. And there should be flags in a few other places. But the point of this image is that the centers are concentrated in North America and in Western Europe. So even though FTD has been recognized in many countries, the scope of activity and research activity and clinical activity varies widely across regions. And that reflects the availability of expertise. It affects what resources can be brought to bear, both for care and for research. It reflects public health priorities, and then of course it reflects socio-cultural factors. So to make progress in developing FTD care and FTD treatment, it's important to begin to grapple with these issues. With the distribution and demographics of frontotemporal dementia, we need to a finer understanding of the frequency of FTD across areas of the world. We need to understand how clinical presentations may vary as a result of the cultural environment rather than simply the syndrome. We need to understand if the genetic mutations that have been described so far are distributed widely across the world and evenly or not. And most importantly, we need to understand how the diverse settings impact diagnosis, care, and research. We need to understand that in a quantitative way. Today, these FTD centers are involved in a scope of activity, in a wide variety of activities that are intended to move us in this direction. In the direction of understanding how the disease is spread through the world, understanding how to measure it clinically, and those measurements, of course, are relevant to drug development and to clinical trials, to understand the neuropathology, the genetics, because that is how that's what will tell us the pathophysiology, what the broken parts are, how they've gotten broken, how that damage translates to symptoms, and that's at the heart of drug development as well. And of course, imaging and neurophysiology also contribute both to our understanding of the disease as well as the development of treatments. Advocacy, as you know, is very important. Much of the success that the FTD field has experienced would not be possible without the participation of the community at large, meaning people who have lived with this disease or whose families have been touched by it and who have come together and partnered with the research community, with the clinician community to drive public education, professional education, public action, fundraising, and to watch the growth, for example, of the Association for Frontotemporal Degeneration, the AFTD, over the years. For someone like me who came when it was small and we could all fit in a restaurant, it's been amazing. And so the major developments in the last 50 years and frontotemporal dementia, essentially, and this is research, as I say, coming from the various centers, include describing prevalence and incidence. Now that most of that work has come from 18 countries that are mostly concentrated in North America and Western Europe, but there's also been substantial contributions from investigators in Japan, also from South Korea. Major phenotypes, as we've seen, have been defined, along with their radiological, genetic, pathological aspects. We now have robust diagnostic rules, although the sensitivity and specificity is not well understood, especially when you think across cultures. And we'll be coming back to that point. Mean life expectancy, which is 8 to 10 years, is mostly defined on the basis of data that has come from the North American and European cohorts. At this time, there isn't much information that tells us what beyond having the disease might influence life expectancy. For example, does having FTD plus diabetes make a difference in one's life expectancy? FTD versus hypertension. Does it matter how well the hypertension might be treated? Does it matter if one also has thyroid disease? These kinds of things are things that strike at the heart of living with the condition, and much of that work has not yet been done. And then one has to then contend with with other cultural factors, and we'll see some things about that as we go further. Now, age and education influence the expression of illness, but the effects of other sociocultural factors are not yet understood. Major causal mutations, we believe, are being identified along with their correlates, and treatments and models of care are now being used to try to improve lives, although these still remain, as we all know, works in progress. We have a strong advocacy community, as I've mentioned, and we now have an integrated model of the disease that allows us to begin to integrate findings from clinical work, from biomarker work, from molecular science, into models of what is happening in the brain before a person manifests the earliest symptoms, so before people will cross this line, which is when some symptoms have appeared. What are the changes? So the clinical status is normal until they cross this line, but brain volume, brain atrophy has already begun. Some other molecular events have already begun, and they accelerate in the zone between early symptoms and full-blown illness. We're beginning to understand this, we're beginning to model it, and this is crucial information for treatment development. What we still will need to do on top of this sort of biological model is to understand what other factors shape the expression and recognition of symptoms, because that's crucial to defining where this line lies, for example, or that line. It's crucial for defining for case identification. We need portable case identification. Why do I say that? Well, at this time, one of the reasons we have major centers and most of the research is concentrated in these centers is because of that diagnostic complexity. The complexity of the illness, the complexity of the diagnostic process. We need portable case definitions that will help us move the diagnostic process into primary care settings without losing too much accuracy. We need language and culture translations of clinical measures to make that happen. We need to understand the geographic distribution of syndromes as well as the larger population and genetic risk factors. That's going to be crucial for screening. We need psychosocial determinants of disability. We need to understand the determinants of disability and of how the experience plays out on an individual to individual basis. And a lot of this is going to be about the social cultural environment in which a person is. And then we need a lot of that information to design, validate, and implement interventions. And I'm not talking about pills, but interventions that help to improve lives. And there's a crucial question, which is especially germane in the United States, which is targeting recruitment so that the benefits of research, the insights that are derived from research, are generalizable to every community and not to a subset. So today we have discoveries that are mostly based on research from people who participate, who are typically high socioeconomic status people, so people who are more affluent. They represent the majority in the United States. That means they represent the European American community. And there's today a high barrier for access to research centers and to the information about FTD, and that has to do to a large extent with the complexity of the illness and the work that remains to be done to put that information where it is more easily reached, and to, if you will, make it easier for people who are not experts to make the diagnosis. Now, when you look beyond the North America and Western Europe, then you run into the issue of limited expertise and infrastructure in many regions. So there's an uneven distribution of clinical care, of research expertise. There are gaps in understanding if the differences in phenotype expression, and there are gaps in understanding risk factors beyond genetics. So a lot of places are working off of data. I mean, a lot of the work that's done in regions, for example, in Africa, is based on data that is derived in North America and in Western Europe. There isn't much data there isn't local context data, if you will. And so that there's going to need to be an effort to develop that. Just to illustrate the importance of understanding local context, it's now known that genetically determined FTD, so hereditary FTD caused by C9, MAPT, and progranulin mutations, which are the major mutations that cause FTD, are rarely observed in the Asian community, or in Asia, whether you're looking in Japan, in Korea, in India, or elsewhere. There have been some mutations described in China. We don't know if this is common or not, but it seems that their mutation frequency may be higher in China than in other areas of Asia, and that needs to be explained. Now, this is work that Amitabh Ghosh conducted in India 8 years ago. What he was looking at is the utility of the current diagnostic criteria in an Asian environment, specifically in India, in Calcutta, India. And what he found was that within the first year of presentation, most people already had a florid illness that met the majority were already had enough symptoms to easily check off practically every clinical criterion for FTD. And by 2 years, even more people will have that. And so all the patients, 48 of them that were tested in this study, met diagnostic criteria off the bat. Most of them checked off every single criterion. And the point being that they present in a very florid state when the FTD is very obvious. And initially it was thought that perhaps they have a more acute presentation, but we now know that that's probably has to do with health seeking, with modes of understanding the illness, with local beliefs, both within, in the population as well as with the providers, and with the health seeking context. But it may also have to do with issues around what social cognition means in that cultural context. So as we might appreciate expressiveness and how acceptable it might be, and the rules around expression of emotion vary across cultures, and that can have a significant impact on the interpretation of diagnostic criteria, particularly when it comes to things like disinhibition. Now, what do we know about people of African descent? Well, there's no research coming out of Africa at the moment. Well, no major studies coming out of Africa. There's a little bit of data, mostly single case studies. But what Keith Josephs and I were able to do a number of years ago was to collect data from centers around the world, which are listed in the slide, in the United States mostly, in the United Kingdom also, in Nigeria and in Jamaica. So this is clinical data from 66 people who were classified based on where they were born and raised as either African, African American, or Afro-Caribbean. And the age at onset mirrors what we already know. So before age 60, a number of them had familial FTD. I think there were 3 cases of C9orf72 mutation. These were in people in the United States. The behavioral phenotype was common, but also the semantic dementia phenotype was also observed. And neuropsychiatric symptoms were very common. And so if you look to your left, you can see the frequency of these neuropsychiatric symptoms. So the most common seems to be disinhibition, but they had high rates, or relatively high rates, of hallucinations and delusions. Now, this is obviously preliminary, and would need more research for us to know if this is the typical picture. But as one might imagine, if indeed this is true, what it may mean is that African American patients will have a high burden of neuropsychiatric symptoms that might route them into the psychiatric space and cause them to be first diagnosed with psychiatric disorders, maybe disproportionately so, and contribute to diagnostic delay. So that is something to look at. Now, other aspects of social context. Multilingualism, for example, has been investigated in India. This is work that's been done by Ratnavali Elajusulia, by Suvana Aladi. Some of this shows that there's a hierarchical loss of language functions in frontotemporal dementia. Multilingualism, some of you may know, is ubiquitous in India. It's in fact the norm. And it turns out that people tend to lose the most recent language first. But the phenotype, the symptom, the manner of losing that language function mirrors what we would expect for frontotemporal dementia in general. So we're learning something about how language is represented in the brain, and we're also learning that communication functions can be preserved by multilingualism. Furthermore, cognitive resilience, and this is Suvana's work, seems to be better. In other words, progression seems to be a little slower in those who are multilingual compared to those who are not, who are less so. Thinking about culture and complications, Shin Shinagawa, who co-wrote the paper that Sharon mentioned at the beginning, did a study a number of years ago looking at overeating in frontotemporal dementia. And what he found was that the patients in Japan did not gain weight, did not gain that much weight, whereas the patients that he looked at who were in the UK gained quite a bit of weight and had complications from that weight gain. Now, when he took measures of the severity of the hyperphagia, what he found was that there wasn't that much difference in terms of the symptom, but there was a big discrepancy in terms of the consequences. And that came down to the local diet. And so as a result of dietary, of the cultural diet, the people in the United Kingdom had much worse outcomes as a result of hyperphagia compared to those in Japan. So this perhaps provides some clues about how we might manage the complications of hyperphagia when it comes to thinking about treatment. So, as I've mentioned, social context and the norms will influence how we define the phenotypes. They'll influence clinical measurement, case detection, and the clinical course. On top of that, local practices which have to do with things like explanatory models. There's been research that's been done in Nigeria, for example, has shown that religio-magical systems of thought that confer religious meaning to symptoms can result in people being diverted from the clinical space to a revival or to some other sort of religious ceremony with the idea of treating the illness, casting out demons and the like. And that can result not only in a lot of diagnostic delay, but in a lot of suffering. Beyond that, there are help-seeking practice issues, people explaining away dementia as part of aging. And it should also be noted that the religio-magical thinking is often in many places not just a function of the patients themselves, but also of the providers who they come to see. And so these are the sorts of things that will need a lot of work. To deal with these, we're going to, as I mentioned earlier, have to contend with the limited infrastructure and expertise in many regions, the gaps in our understanding of these cultural influences and how they operate, the low levels of knowledge and late recognition in the resource-poor regions, the lack of care sophistication and resources. Now, here, what I mean by care sophistication is, for example, you contrast North America and Western Europe with Africa, where in the former, residential care systems, daycare centers, these are very well developed. In Africa, there's no such thing. So care devolves to family and extended family. And that has its limits. And that is also it's a reflection of culture. It is a reflection also of resources. So the key, I think, will be to integrate, as I mentioned earlier, social-cultural factors into our FTD models, disease models, so that we can understand how the symptoms develop. We can understand better ways to identify how we identify cases in a way that is meaningful for the research, how we develop and translate and interpret clinical measures, how we make sure that what we discover is generalizable to everyone, and how, in short, it is clear that social-cultural factors will be very important in a full understanding of how the disease develops, evolves, causes suffering, and it will be very informative for designing interventions, including biological interventions. There are many. The good news, I should say, the good news is that there are many initiatives on their way today. There's the frontotemporal dementia, the FTD Prevention Initiative, or FPI, which is actively uniting the major research cohorts around the world, including those in the United States, in North America and South America, in Northern Europe, Australia, New Zealand, in Asia. There's an active process to create essentially a global community of research. The International Society, which is a professional society, is doing a similar thing on the professional level. Already some major centers, such as UCSF, the California group, the San Francisco group, are already in formal collaborations with South American centers, in the same spirit. And then the ISTART, which is the professional arm of the Alzheimer's Association, has a frontotemporal dementia professional interest area, which I am involved in. And we have recently started an initiative bringing us into collaboration with the diversity professional interest area that has been instrumental in looking at socio-cultural factors and their impact on Alzheimer's disease. And so we're trying to bring that expertise, partner it with FTD knowledge, so that we can stimulate research in that direction. So we have essentially dealing with the cultural issue impacts of the cultural undercurrents of frontotemporal dementia will require an international perspective, a concerted international effort to build networks, to build communities that drive innovation through exchange. And I don't say collaboration in the sense of doing research together or doing things together, but real-time exchange, where the kind of exchange that you might have, for example, in your family WhatsApp group, where there's constant chatter. But we can exchange experiences. I visited a residential care community in Berlin a number of years ago, and I was astounded. I didn't think that residential care can be done in different ways. I thought there was, that you bring people into a place where there are providers to help look after them, and that's that. But it turns out that there are different models. But you don't know that unless you see it and hear it and learn it. That means exchange. I've already mentioned the community of research that is developing through the FPI within the FTD community, the international FTD community, within the ISTAT peers, which is bridging Alzheimer's and FTD world communities. But we also, I know that the AFTD has long been involved in trying to do similar work on the advocacy level, bridging and establishing communities of care that are global, or networks of care that are global. And then we could also strive for a community of practice. What all of this will be doing is leveraging commonality of purpose, and it will require exploiting communication technologies, because it is not enough to simply travel to somewhere and have a national a big meeting, international conference. It has to also involve real-time exchange, and a lot of that will require asymmetric communication. So I hope that I have provoked some thought. I hope we have enough time for questions, for some of your questions. And as this sort of thinking cannot be done alone. So these are my acknowledgements. Thank you very much for your attention.
Dr. Onyike, thank you so much for being with us today.
Thank you.
And it really is a very challenging presentation. I know that bringing this global perspective to the research and all these really complex issues you articulated it so well in terms of the challenges that are ahead of us. I think we have time for one quick question, because I'd really like to get your perspective. We know that there's such a lack of diversity in the community that we serve and that we interact with all the time here in the US. I hear from your comments that, with the preponderance of sites and FTD centers in North America and in Europe, we may have an additional responsibility to begin to change things here in the US in terms of reaching underserved communities, bringing them into the diagnostic process, and being able to incorporate them and include them more and more into the work that we're doing, as it's also filtering out internationally. In a really brief moment before they cut us off, could you just speak for a little bit to any efforts you're aware of that you think are really effective at broadening that reach and that inclusion at the community level here in the US?
Yeah, one of the ways to do this is to have one of the things that has worked in the Alzheimer field is what they call community advisory boards, and so that this means involving identifying thought leaders within the African American community in this case, but it could also be within the Hispanic community or some other group. But identifying community leaders that you can then partner with to understand, to learn where do they get care from, because then you can reach out to those providers and begin to do the education that needs to be done to sensitize them. The other thing is to create buy-in and to gain their understanding about the right ways to package the messages and where to present the messages. So, for example, there is a lot of activity around churches when it comes to the African American community. So a lot of the outreach happens through health fairs that are put on by the churches. So that's one sort of opportunity. The other is to systematically identify within the AFTD's existing network people who are from these communities, and you could do focus groups, for example, to sort of gain ideas that you can then road test. So those would be some of the ways. And then the final thought might be to look at the historically black or the universities that are in urban centers, those that focus specifically on minority communities. So places like Howard University, Meharry, and see if there is an opportunity. I don't know that there's necessarily opportunity at those places, but it might be worth exploring.
Thank you very much. We are out of time, but I really appreciate your insights and framing these issues for us. It is something that AFTD is really committed to working on across our constituent groups, and I hope that we'll continue to partner with you in some of these efforts as well.
Yes,
so
absolutely.
Thank you very much for being with us today.
Thank you for having me, and thank you.